to CannabizMD Profile. I am Jacquie Cohen Roth, founder and CEO of CannabizMD and TPAD. CannabizMD is focused on filling the void of cannabis science and policy education via conversations like the one I'm about to have with Dr. Tishler, the upcoming Cannabis Science and Policy Forum, our content-rich website, CannabizMD.com, education programs, as well as consulting. We execute our mission to engage, educate, and build a network of industry stakeholders that are focused on delivering optimal patient outcomes as well as establishing industry best standards. The profile conversations like the one that I'm about to have are with cannabis industry founders, scientists, physicians, policy influencers, and entrepreneurs, people who are impacting the cannabis industry and are committed to establishing those industry best practices with a shared commitment to quality medical patient care. And welcome to Dr. Tishler.
Thank you. Thank you for having me on today.
Thank you. Dr. Tishler is a cannabis specialist. Through his training in internal medicine and years of practice as an emergency physician, Dr. Tishler brings his knowledge, reason, and caring to patients. At the medical cannabis practice he founded, InhaleMD, and through his advocacy work at the local and national levels. Dr. Tishler graduated from Harvard College and Harvard Medical School. He trained at Brigham and Women's Hospital and is faculty at both Brigham and Women's Hospital and Harvard Medical School. He spent many years working with the underserved, particularly providing care for veterans. Having treated countless patients harmed by alcohol and drugs, his observation that he had never seen a cannabis overdose led Dr. Tishler to delve deeply into the science of cannabis safety and treatment. He's president of the Association of Cannabinoid Specialists, which aims to educate clinicians, lawmakers, and the industry about best practices and the needed tools for proper patient care. Obviously, a very like-minded organization with the values of CannabizMD. Dr. Tishler is the keynote speaker at the third annual CannabizMD Cannabis Science and Policy Forum, hosted on September 24th. Post the virtual world of COVID, I'm very excited that we're going to be hosting a hybrid forum this year, coming from the University of Maryland Biopark and on Zoom. Following Dr. Tishler's keynote, Cannabis Policy, Politics, and Patient Care, are three roundtable discussions with national cannabis experts focused on clinical and research applications of medical cannabis, regulatory considerations for clinical practice and research, and then the last roundtable focuses on emerging trends and innovations in the medical cannabis industry. More information and the full list of panel members can be found on CannabizMD.com. So Dr. Tishler, we've got lots to cover.
Excellent.
Ready to go?
Absolutely. Let's go.
Okay. So in the introduction, it was a very powerful observation of yours that you observed that nobody had ever died of a cannabis overdose. And that if you would share more about what was so intriguing to you about to first start to delve into and educate yourself on medical cannabis, and then, of course, leading to the founding of InhaleMD.
You know, it really was kind of an organic process. You know, I was working as the emergency room doc at the VA for years. I worked for the VA for about 15 years in total. And, you know, when you work in the VA in the emergency room, you get to see a lot of stuff. And in fact, you know, I've often been told I could write a book just about that experience itself. The stories are numerous and mind-blowing, but one of the things that that comes up is you start to see a lot of these drug and alcohol complications. You know, even guys who come in and they come in for something that's fairly sort of conventional, like they have chest pain or something like that. In this setting, it's often complicated by the overlay of these other substance-related issues. So I sort of became a bit of an expert at this acute presentation of various kinds of intoxication and its long-term harms. And then back in sort of 2011, Massachusetts had started to talk about medical cannabis, which was kind of a novel concept. And And I started to think, well, you know, if cannabis is so harmful, why am I not seeing it in my emergency room, right? I would see veterans who would come in and their problem list, right, their list of diagnoses would include, you know, cannabis use disorder or whatever we were calling it at that time, but they were never coming in because of that problem, right? They were coming in for something else, and this was just a curiosity on the list. And so I was starting to say, well, look, you know, here's a group of people who have this diagnosis, but this isn't their problem. And ultimately, I sort of said, look, if all of these other substances, and alcohol is a great example, because really alcohol was sort of 1 through 9 on the top 10 list of who I was seeing. You know, if these substances are dramatically harming our veterans, really ruining their lives, and they're freely available, and cannabis can be used in a therapeutic context, why are we not doing this? But it left open the question of really, okay, is there a therapeutic context here? And in 2011, that was much less evident than it is now. And so that's what led me into spending literally several years diving through this literature. You can remember that sort of at that time, there were certain politicians that were being questioned about their views on medical cannabis, who said things like, well, there's no data, there's no research. And I think everybody sort of bought that line, hook, line, and sinker. The reality, however, at that time was that if you went to PubMed, which is kind of the Google for science, and you put the word cannabis in, you would only get 25,000 studies. And 25,000 studies is a daunting number of studies. At the same time, if you went and put the word alcohol in, you got about 5,000 studies. So clearly the idea that there was no research on cannabis was absolute bullcrap, shall we say. The larger question was, when you're confronted with 25,000 studies, how do you make any sense of that? And that's why it really took me years of sort of combing through this to assemble what felt like enough knowledge and understanding about what it can do, what it can't do, what are the side effects, what are the risks, to then be able to say, all right, I could sit down and actually take care of a patient in a meaningful, safe, and appropriate manner. And that's sort of started me to think, all right, I have all this knowledge, my colleagues don't, the patients need this. I kind of felt, okay, this is my Boy Scout moment. I'm sort of duty bound to kind of provide this to the community, both to patients and also then to go back to my colleagues, you know, and say, look, you know what, we actually have this data. This is legitimate. Here's what I can tell you. This is not my opinion. These are facts. You know, here are the studies. And that really was the beginning of my private practice. I often say, look, I never wanted to be in private practice. That wasn't the goal. I mean, there's some people who are entrepreneurial that way and they want to be in private practice, but that wasn't my goal. The issue was that I wanted to be able to take care of patients using these medications. And you can imagine working for the VA, that was a non-starter. But even working for a large medical hospital system like the Brigham Women's Hospital, where all of their funding is from the government, really, you know, that was also a non-starter. So starting a private practice was really the only place where I could get this treatment to patients, as well as become a forum for talking to my colleagues. And that's really how we got started in this. Thankfully, that's a long time ago now.
Yeah, and yeah, fast forward, what are we, 11 years? So congratulations. And to your point that you had made about your colleagues not having the familiarity with medical cannabis or the knowledge, and this is because cannabis is a Schedule 1 drug, meaning that it has no acceptance, medical use, and a high potential for abuse. And of course, this is by the government, and so that severely limits the opportunity to conduct those gold standard FDA studies. However, you spoke to, there are 25,000, or that you found, there are more than that now, but that you found 11 years ago. So the my understanding is that the pushback from physicians, that again, backtracking on the education, that only 9% of medical schools include cannabis science education in their respective curriculum. So Two-part question on this is, um, with your on faculty at two medical schools, are they including any context on medical cannabis in their curriculum?
So actually, it's only one medical school, that
Not
being
Harvard.
medical school, and then the Brigham and Women's Hospital is a hospital associated with the medical school.
Okay,
Um,
great, thank you.
no, not yet. I have been after them for years upon years, and have received very lukewarm response, as one can imagine. I've tried to convince them that this belongs in the sort of first couple years of medical education, which is kind of the book learning part of the medical education. They said, oh, well, we don't really have room for that in the curriculum, and we have a few people touching on it in the psychiatry, section and that sort of thing. They were really pretty lukewarm about that. I tried to put together a rotation for later medical students that didn't meet with a lot of enthusiasm. Where I have met with success, which obviously is much more important, is I do have a rotation that's ongoing for medical residents. So those are the people who graduated from their medical schools and now are doing the hard work of actually learning to practice medicine. And I've had bunches of them come through, spending a couple weeks with me in the clinic, seeing how we practice medicine. So that's been a major step forward. And I'm still in touch with a number of those students. And then the other thing that's very exciting is I'm right now working on a CME curriculum with the medical school. It's not aimed at students, but it's aimed at practicing physicians and those practitioners, and really focusing on not people who are going to be specialists like myself, but rather the practicing docs, whether we're talking about primary care or neurology or psychiatry, or all of those guys who are out there sort of encountering our patients, sort of at first blush, and needing to know that cannabis or cannabinoids are a viable option, who would benefit, who would not benefit, and when to refer. This gets really at the heart of an important model, which is that sort of unlike the model that was put forward in the mid 1990s in California, where the idea was sort of any doc would just kind of write a yes or no permission slip, if you will. We've really moved to the point where there's a lot to know, and there's a lot of time and patient interaction that needs to go into making sure that the patient is getting what they need therapeutically. And that's good. That is an advance that allows us to take better care of our patients, but it also means that our primary care folk don't have the time to do this. They're already beyond stressed out, seeing patients and covering all the things that they need to cover in usually a very limited amount of time, sort of 10 to 15 minutes. And we can discuss at length how ridiculous the idea of having a primary care visit is in 15 minutes, but that's what the money guys are allowing at the moment. There's nothing in modern medicine in America that couldn't be fixed by fixing the payment system. But that is above my pay grade. But it is the point being is that those docs need to understand cannabis as a medicine, not because they can or want to do this kind of medicine, but because they need to know who to refer to somebody like myself, who's then going to spend an hour with that patient talking about nothing but cannabinoid medicine and their illness and their progress, and then follow their patients and make sure that they're getting the right medicine, the right outcomes, and all those sorts of things. And so that's why I really believe that this, at least for now, this has to be viewed as a specialty unto itself.
Thank you for that. And so referral patterns from, you spoke about the primary care, but what about the specialists that, thinking about chronic pain specialists, what's a referral pattern look like for you?
One of the things that's been very interesting to watch over the years has been the changes in these referral patterns. When I started, as you can imagine, it was almost entirely self-referral. And people would come in and say, look, my doctors have suggested all these medicines. I've tried them, that they haven't worked for me. I'm kind of at the end of my rope, and you know, and they don't seem to have anything more to offer me. So what can you do for me? Um, and oftentimes at that time, historically, people would say things like, "Don't tell my docs." You know, I don't want anybody knowing this. And I worked hard over the last whatever it is, 10 or so years to really change that whole scenario. Sure, we still get self referrals, but mostly that whole "don't tell my doc" thing has gone away, which I think is important, because if you're practicing medicine, all of the people on the care team really need to know what's going on so that they can provide appropriate and informed care. And so really we don't hear too much of the "don't tell my docs" thing anymore, which is lovely. But the other thing that's changed over that period of time is that the balance has shifted, and most of my patients are now coming from their docs.
That's great.
It's wonderful. So I would say it's 60 or 70% by referral from my colleagues at this point. And that's been through a lot of effort on my part to educate those docs. It's still the next hurdle is that even amongst the patients who are coming with a referral from their clinicians, it's usually because the patient brought it up, right? So the doc's not thinking necessarily about cannabis. The patient says, "Well, what about cannabis?" And they say, "I don't know, but you can go talk to Jordan. Here's how to reach Dr. Tishler." And so that's a step forward, but where the next step, and this is part of why I think we need this CME program that I'm putting together with the medical school, is that we need doctors to be thinking of it on their own, right? And so Mrs. Jones comes in with back pain, and the doc says, you know, "I could give you opioids for your back pain, but I think I'd rather see you using a cannabinoid, so go see Dr. Tishler." And that sort of doctor-initiated conversation happens fairly infrequently, but it's not zero. And we need to improve that. And I think that that's where the mission of education for these referring providers comes in at this point.
Yeah, that critical need. Oh, and how about your patient population? So we have, you know, the industry data supports that it's from millennials through folks in their 80s, and whether it's the millennials is the largest group of patients using medical cannabis or the seniors. And with your with your patient population in your particular practice, what segment is the largest demographic?
So you left out the Gen Xers, and I feel personally offended. But so I would say that the older crowd is definitely the larger crowd.
Yeah.
You know, when we're talking about folks in that sort of 60+ age group, you know, there's just a natural, unfortunate progression of the human condition, where we develop ongoing problems that thankfully are amenable to cannabis treatment. So whether we're talking about arthritis pain, or we're talking about sort of end of life anxiety, or we're talking about insomnia that just seems to occur more in people as they age, all of these things are importantly treatable with cannabinoid medicines. In the middle age group, we have mostly folks who have some with anxiety, but mostly they're the people who have developed cancer, and then all of the things that go along with that. And then I also do have a smattering of younger folks. It's definitely the smallest group, and that includes people with severe anxiety disorder, not like, "Oh, I feel a little nervous today," but people who've had lifelong anxiety. They've been on multiple medications and they're still not doing super well. We've got folks who have, you know, Asperger's or autism spectrum disorder, and those sorts of things. And of course, unfortunately, a small smattering of cancer victims as well in that age group. So it's pretty varied, but without question, the older crowd is really the bulk of what we're seeing.
How about the delivery methods that you were recommending for your older demographic?
Well, there's no question that the older demographic is less interested in smoking. And what I say is great, because I don't recommend that anybody smoke cannabis. But one of the things that I think is less widely understood is that the way in which we take cannabis dramatically influences how it behaves for us as a medicine. And
Right.
therefore, we need to take it the right way for what we're treating. And so, sort of on the more recreational side, or from that perspective, there's sort of this, well, what do you want to do kind of perspective. And unfortunately, when we're really thinking about this medically, it's less about what do you want to do and more about what's going to work best for you. And so what I often say is, look, there are a million different ways that you can take cannabis. Some of them work more effectively than others. And if we're thinking about the things that are most effective, we're really talking about inhalation on one hand and edibles or oral on the other. And they're vastly different. And most of the people who are watching this are going to understand this, that when we inhale cannabis, it's very rapid onset, but relatively short duration. Whereas the edibles are quite the opposite, right? It's slow to work, but it works longer when it gets going. And so that makes the use cases different. If somebody comes in and they have migraines, which we know from the conventional studies need to be treated quickly before they get out of hand, then giving them a gummy is just barking up the wrong tree, because it will be out of hand before the gummy works. So that's somebody who really needs inhalation. Whereas somebody who has sort of 24/7 back pain, we know that inhalation, just like short-acting opioids, leads to kind of this yo-yo effect that actually worsens their pain and increases the amount of the total daily dose of the THC that they would be taking, whereas giving them the long-acting edible form gives them a nice, steady control of pain, and it's much more effective for them. So again, it really does come down to what are we treating?
And so you practice InhaleMD based in Massachusetts, which is adult use. And what has been, or have you seen an impact of on your patients and folks that are coming to you with the impact of the adult use? Any change?
Oh yeah, absolutely. I think that it's interesting that everybody has latched on to this expression adult use. I actually dislike that term very much, because it sort of implies that anybody who's an adult should use this for any purpose, and that is a good business marketing case for people being convinced that they don't need to see a doctor, that they should just come in and sort of treat themselves with the guidance of a bud tender. And I think that is, I think that, how do I put this? I think that does a disservice to patients who are sick and reasonably deserve the knowledge and guidance of somebody who spent their life doing not only cannabis, but medicine, right? And
Right.
kind of puts these things together to get to the best outcome. So I tend to like to think of it as, look, we've got medical for people who have a problem, and we've got recreational for people who are interested in having fun and relaxing and that sort of thing. And so the point being is that in Massachusetts, where we do have recreational, to your question, yeah, I've seen this be very harmful. I think that the attitudes in even the medical dispensaries have become more and more sort of recreationally oriented. This leads to my patients often being talked into all kinds of things that they don't need, that are very expensive, and that sort of derail their trip from illness to wellness, and spend a ton of money that they didn't need to spend. But also there's a lot of marketing going on out there. I mean, not just paid marketing, but basically all of the discussion in the news media is about what is the commission doing on the recreational side, and almost nobody is talking about medical anymore. So if somebody is thinking cannabis, they're thinking along those recreational lines, simply because there's very little saying, yes, this can be done medically, and here's how you get to the doctors who are going to help you with this. So I think that the recreational industry has very much harmed patients, and in its current form really doesn't provide, the cannabis industry on both sides of the aisle does not provide adequate facilities for taking care of patients. And that's one of the things I think we need to see change. Clearly, medical was the beginning toward recreational legalization. People accuse that of being a Trojan horse, and there's some truth to that from a policy perspective. But the reality here is that cannabis does make good medicine. And so when we're done being giddy about how wonderful it is that we can all legally smoke a joint, then we really need to circle back and start to say, all right, now how do we get serious about this so that patients get what they need and they get the right thing and they get it in a timely fashion?
With that, thank you for that. So two points that I'd like to tease out of that is one, so you'd like to shift the conversation from using the phrase adult use to recreational.
Right. And I think, people sort of counter that by saying, well, people use cannabis for all sorts of reasons. And, maybe they're treating their anxiety or something like that. And I would say, look, anxiety is a serious illness.
Yes.
And
Yeah.
so, to me, it's shameful that we're trying to convince people to just go buy a bottle of CBD or CBG or whatever it is that's kind of mail order, over the counter, whatever, to treat their anxiety without sort of acknowledging that this is a medical problem and that there are people like myself who've spent our lives learning and being dedicated to helping people who can help people get control of their anxiety, right?
Mm-hmm.
Instead of kind of going down to the store and buying a bunch of stuff and kind of fumbling your way through it, come talk to somebody like myself who can say, you know what, this isn't going to work. This isn't going to work. This isn't going to work. This is where we need to be pointing the ship. It gets us to the right answer sooner, cheaper, and safer. So that's kind of, look, I've got no problem with recreational use of cannabis. I have a problem with the industry sort of trying to convince people who otherwise would benefit from medical care that they should just DIY it.
Yeah, so and that is a very critical issue that is needed to be addressed in the industry. Is that essentially these dispensary attendants, bud tenders, are the front line with the patients, consumers, and these are folks who, recent high school graduates, um, and again, they don't have the clinical training that you have, and folks, other clinicians in the that are recommending cannabis. So, how do you overcome? And what conversations do you have with your patients that oftentimes is that you're making a particular recommendation or a specific recommendation for, I'd like you to go in, I'd like you to get a tincture, and whatever you recommend, they go to the dispensary. Oh, we don't have that. Oh, this works much better. We all have our horror stories of patients that we've consulted with on what happens when they actually go into the dispensary and what they come out with. So, what do you say to your patients? Do you give them any warning? You're like, put blinders on, don't listen to anything that they have to say. How do you overcome this?
Well, it's interesting. I said earlier that I spend an hour with each patient, and unfortunately, a very sizable percentage of that time is doing what you're just saying, which is, devoted to not only educating them, but warning them about all of this sort of misdirection of
That's so
contact.
unfortunate that you're going in to get medicine, and if you would, equate this. So I'm going into a pharmacy, and I'm going to go pick up, my opioids or my, whatever product, drug,
Yep.
pharmaceutical product it is. Pharmacist isn't going to challenge you or say, "Oh, nope, you don't want that. Go over here. It's a lot more expensive, but it's going to treat you better."
Well, I think you bring up a really key point, which is very connected to the talk that I'm going to give next month. The reality here is the pharmacists don't do that because the law prevents them from doing that.
Mm-hmm.
If you go in with your blood pressure prescription, the reason they don't say, hey, would you like a side of Percocet with that? Is because
Right.
they can't, and I suspect that if they could, they would. And at a certain time in history, about 100 years ago, they did. And then the laws were created to ensure that patients got what they needed without sort of this upselling and side selling tactics. And I think that that's kind of the point I need to make, which is that right now we don't have adequate regulation around this interaction And so we need at the federal level a unified national policy that includes a whole bunch of kind of key points.
Mm-hmm.
One of which is that the clinicians need to write a prescription, right? That
Mm-hmm.
puts the burden on the doctor to know what she's talking about and to be specific about the particular prescription.
Mm-hmm.
So, that knowledge, that requirement should fall on us as the knowledgeable provider. But then the flip side of that is then the point of sale people have to be required to honor it. Otherwise, then it's spitting in the wind. And I will say that I send my patients a whole bunch of information after our visit, one of which is my prescription. And I use the air quotes because it doesn't go to the dispensary and the dispensary doesn't honor it, but I send it to my patients because that is a means of communicating to them what it is I want them to get and what I want, how to use it. And for a long time, back before the pandemic, when I was seeing patients in person and then they were all going to the dispensary in person, I did have them take that piece of paper to the dispensary, and the dispensary people would look at it and scratch their head and not know what to do with it. And so I started to give talks to the dispensary people. Here's my prescription. This is what it means. Please don't change anything. My prescription actually at the top, it has in big red letters in a big red box. It says, dear patient service advocate,
That's great.
please do not change this prescription. If you have any questions or concerns, here's my phone number. Please call me. Which is the way things work in the pharmacy world. If the pharmacist looks at prescription and says, this doesn't make any sense, there are too many zeros here, I can't read the writing, blah, 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 they call you and they say, hey, doc, what do you mean? Let's fix this. And there's a lovely collegiality to that, so anyway, you can guess how many calls I've gotten from the bud tender. Actually, I think it's up to 2 now.
Oh my goodness.
Which is better than it used to be, which was 0.
Zero?
But oftentimes of those 2, it's been sort of like, why are you writing this thing? And just let us give them whatever we want. And that's a whole different discussion. One of the things that we've done at the Association of Cannabinoid Specialists is we've put together a course for bud tenders. And it's relatively short. It's less than $20. We wanted to make sure it was affordable to all of the bud tenders. And what does it cover? It covers some basic science, right? It talks about, what are milligrams? What are milliliters? What is a concentration? Stuff that, I'm sure that they saw in either junior high school or early high school math and science classes that most people weren't paying attention to unless they were a nerd like myself. And so, but now it's relevant to their job. And so we need to kind of go over that sort of stuff. And then the sort of second half of that is, a kind of stuff about professionalism. How do you deal with a patient? How do you deal with the doctor in a way that's constructive, and that sort of thing? And these are, it's not meant to teach the bud tenders everything they need to know about cannabis or how to sell in a dispensary, because there are plenty of courses on that sort of thing. This is really an additional thing, which is really aimed at saying, all right, so now you're a bud tender, you're going to be getting referrals from doctors. How do you deal with that? What does it mean? And how do you make sure you're pulling on the oars in the right direction as part of the team?
I think that's a fantastic approach to engage both of those folks that are dealing with the patient. And so again, the idea and the goal is optimal patient care. So I'm going to wrap this up. We've covered, I think, some really interesting topics of discussion and what you're going to be speaking about at September 24th at the CannabizMD Cannabis Science and Policy. Again, your keynote, Cannabis Policy, Politics, and Patient Care. If folks would like to learn more about the Association for Cannabinoid Specialists, where should they go?
They should hit our website, which is cannaspecialists.org. Again, cannaspecialists.org. And we've
Excellent.
got all kinds of material for people there.
Okay, terrific. Well, I very much look forward to seeing you in real life, ROL, on September 24th. And thank you so much for joining me today on a CannabizMD Profile.
My pleasure. Thank you so much.